USMLE style question on X-linked Bruton Agammaglobulinemia. Question: a 7-month-old boy is brought to the pediatrician for recurrent bacterial infections, including otitis media, pneumonia, and sinusitis. His parents note that he has had multiple infections requiring antibiotics since he was 6 months old. He was born full term with an uncomplicated birth history. Physical exam reveals absent tonsils and lymph nodes. Laboratory findings: serum IgG, IgA, IgM, all markedly decreased. B-cell count, absent CD19 plus cells, undetectable. T-cell count, flow cytometry, absent mature B-cells, chest X-ray, normal thymic shadow. Which of the following best explains the pathophysiology of this patient's condition? A. Impaired lysosomal trafficking in phagocytes. B. Defective B-cell maturation due to a tyrosine kinase mutation. C. Failure of T-cell activation due to defective CD40L. D. Inability to form the membrane attack complex, C5-C9 deficiency. E. Defective IL-2 receptor leading to impaired T-cell proliferation. B. Defective B-cell maturation due to a tyrosine kinase mutation. Explanation: this patient presents with X-linked Agammaglobulinemia, XLA, a B-cell immunodeficiency caused by a mutation in the Bruton tyrosine kinase, BTK, gene. The BTK mutation prevents B-cell maturation, leading to severely decreased immunoglobulins IgG, IgA, IgM, absent or markedly decreased mature B-cells, CD19 plus B-cells absent in flow cytometry. Recurrent bacterial infections, especially with encapsulated organisms, S. pneumoniae, H. influenza, Pseudomonas. Absent or hypoplastic lymphoid tissue, e.g. no tonsils, small lymph nodes. Symptoms usually appear after 6 months of age, when maternal IgG is depleted, leading to susceptibility to infections. Key features of X-linked Agammaglobulinemia, XLA. Feature: findings in IgG is inheritance. X-linked recessive, boys affected. Pathophysiology: BTK mutation, no B-cell maturation. Serum immunoglobulins IgG, IgA, IgM. B-cell count CD19 plus, absent. T-cell count CD3 plus, normal. Lymphoid tissue tonsils, LN, absent or very small. Infections: recurrent bacterial, S. pneumoniae, H. influenzae. Enteroviral infections. Age of onset, 6 months after maternal IgG wanes. Treatment: IVIG replacement therapy, antibiotics. Why not the other options? A. Impaired lysosomal trafficking in phagocytes. Describes Chediak-Higashi syndrome, defective phagosome-lysosome fusion, which presents with albinism, neuropathy, and giant granules in neutrophils. C. Failure of T-cell activation due to defective CD40L. Describes hyper-IgM syndrome, CD40L deficiency, which presents with high IgM, low IgG-IgA, and opportunistic infections, e.g. pneumocystis, cryptosporidium. D. Inability to form the membrane attack complex, C5-C9 deficiency. Describes terminal complement deficiency, which causes recurrent Neisseria infections, but does not affect B-cell numbers or Ig levels. E. Defective IL-2 receptor leading to impaired T-cell proliferation. Describes X-linked SEED, which presents with severe viral, bacterial, fungal infections, chronic diarrhea, and absent thymic shadow, not seen in this patient. Key takeaways for USMLE. XLA equal X-linked recessive, mutation in BTK gene, leads to absent mature B-cells, CD19 plus, and low immunoglobulins. Presents after 6 months with recurrent bacterial infections. Absent tonsils lymph nodes are a key clue. Treatment equals IVIG plus antibiotics. Would you like another question on SCID or hyper-IgM